Professor Khalid Amin, Professor Fariduddin, and Dr. Abdustar. It's a matter of great pleasure for me to present this topic in front of distinguished teachers, professors, mentors. So diabetes mellitus is now in the form of global pandemic. Now we have every third person in Pakistan who is suffering from diabetes mellitus. The GI tract is one of the largest organs, starting from the oropharynx, oral cavity, pharynx, which is about 15 centimeter, down to the esophagus, which is about 25 centimeter, stomach, which is about 15 to 20 centimeter. Then we have small intestine, which is about 6 meter long, which consists of jejunum and ileum. And then we have large intestine, which is about 2 meter long, and rectum and anus. And there are other organs like liver, pancreas, spleen, which are associated with the gastrointestinal system. So there are a lot of interactions between the pancreas and our GI tract. And the pancreas, we know that it secretes insulin, which control our glycemia and other functions. It secretes glucagon, insulin, amylin, and other hormones. So this is very important system which is affected by the diabetes mellitus. Thank you for a nice introduction. I have no disclosures. So I am thankful again LDF and PCDA for arranging this conference. My talk will be the GI manifestations of esophagus, stomach, large intestine, small intestine, and liver. So in the pathophysiology, there are 3 important points that, as we know that the diabetes mellitus, it affects our autonomic nervous system, which is sympathetic system and parasympathetic system. And it affects our muscles of GI tract, leading to dysmotility, and there is underlying abnormality in the glycemia, which lead to these complications. So, in the esophagus, we have reflux symptoms, gastroesophageal reflux disease, which is from 24 to 60% of the diabetic populations. And we have many of these patients have dysphagia. And before discussion of the diabetes mellitus leading to dysphagia, we have to rule out other factors like hiatus hernia, transient lower esophageal sphincter relaxation, intra-abdominal pathologies, and other systemic disorders leading to muscular abnormalities. So these all causes, and also the dietary habits and the patient's daily life, which lead to the GERD and its complications. So GERD and dysphagia are common in diabetic patients, and it has an important negative impact on the quality of life in the form of work, abnormalities in the sleep, and the nutritional status of the patient. Hyperglycemia inhibits esophageal motility and lower basal, lower esophageal pressure due to reduction in the parasympathetic and cholinergic activity. So the diagnosis is usually on the clinical grounds, history and examination. But in the patients who are having refractory disease or where the diagnosis is not confirmed on the history, then we need to rule out other diseases and we do the HRM studies, manometry studies to rule out other diseases and to get the information regarding the esophageal acid reflux and the pressures. If untreated, these diseases lead to complications in the form of esophagitis, and esophagitis can lead to upper GI bleeding, esophageal stricture, esophageal adenocarcinoma, and the Barrett's esophagus, which is the abnormal mucosa, altered mucosa, one adult mucosa change to other adult mucosa, which can lead to also to the CA esophagus. So, how we can diagnose and how we can treat? Treatment is mainly lifestyle modifications, glycemic control, weight loss, dietary modifications, physical exercise. So the lifestyle modifications is very important to decrease the weight, to avoid alcohol, smoking, junk foods, healthy regular exercises, healthy regular walking, and avoidance of the junk meal and late night diets which lead to the nighttime reflux symptoms. And among the pharmacological options, we have proton pump inhibitors, we have esomeprazole, we have dexlansoprazole, which is long acting, and we have now PCABs, potassium competitive antagonists, and we have antacids. In the refractory cases, we can do the endoscopic Mughees, and in the patients who are having hiatus hernia and GERD symptoms, we can do the surgery. Mission fundoplication. This is our algorithm for the treatment. The patient having symptoms, which will lead to our 8 to 10 week trial of the standard PPA dose. If no improvement, then we need to do the tests in the form of endoscopy or the pH monitoring. And also in the cases of refractory diseases, we need to do this. If the symptoms are resolved, we put the patient on maintenance treatment. And we need to rule out other diseases and to diagnose and treat them. So coming on the gastric manifestations, there are a lot of patients who are having nausea, vomiting, bloating, abdominal distension. So all our GPs, medical specialists, even surgical specialists and the gastroenterologists, they are dealing with these complaints in our clinic, and these make main bulk of our patients in the OPD. The patients having nausea, feeling of bloating, abdominal distension, early satiety, postprandial fullness, and sometimes postprandial abdominal pain and discomfort. And among the patients who are on the treatment of diabetes, GLP-1 receptor agonists can cause nausea, and alpha glucosidase inhibitors can cause bloating, and GLP-1 can cause again satiety and postprandial fullness. And among the studies done, which showed that gastric emptying is abnormal in 47% of population, or in both type 1 and type 2 diabetes mellitus. So this is a diagrammatic picture of the gastroparesis, abnormal gastric emptying, So when the food goes, then the GLP-1 agonist, the amylin and other hormones in the form of CCK, GLP-1 and other hormones, they cause delay in the gastric emptying. So this is our algorithm. If we have suspected gastroparesis, we need to exclude iatrogenic causes, and we need to do endoscopy to exclude mucosal lesion or obstruction and confirm diagnosis by the scintigraphy or stable isotope breath tests. We have now wireless capsules to look for the delay in the gastric emptying. So dietary modifications, restoration of the fluids and electrolytes, and the patient's pharmacological management of this treatment, pharmacological management of the nausea and vomiting. So this finding that GLP-1 cause delay in the gastric emptying is now being used as a pharmacological treatment for the obesity in the form of liraglutide and semaglutide. So long duration of diabetes, microvascular complications, obesity, smoking, and in abnormalities of these hormones can cause the gastroparesis. So as I have already mentioned, to rule out mechanical obstruction, and then we do the scintigraphy studies. Wireless capsule can also be used, and we give the technetium labeled sulfur diet in the form of egg and the bread mixed with the technetium, and we look for the food present at 1 hour, at 2 hours, and at 4 hours. If it is more than 60% present after 4 hours, then the diagnosis of gastroparesis and scintigraphy on scintigraphy is confirmed. So, and there are other confounding factors. So the management, small frequent meals, low fat and fiber, with more calories as liquids than solids, and easily fragmentable diets. Involvement of dietitian is important, and we need to look for the medications which are causing slowing in the gastric emptying. And we have drugs in the form of metoclopramide, domperidone, and etopride. So mostly we are using metoclopramide, etopride, and domperidone, and we need to look for their side effects as well. Cisapride is not being used nowadays, and prochloropride can also accelerate gastric emptying, but it is more used in the chronic constipation. Jejunal feeding, parenteral feeding, and gastric electrical stimulation, and gastric per oral endoscopic myotomy. We have Professor Lyallpur here, and he is doing these cases, endoscopic management of this gastroparesis. And for the refractory cases, we refer patient for the surgery. So diabetes mellitus and small intestine, mostly for the due to dysmotility, we have small intestinal bacterial overgrowth, and also metformin, GLP-1 receptor agonist, and our SGLT2 inhibitors, alpha glucosidase inhibitors, they all can cause small intestinal abnormalities in the function in the small intestinal abnormalities. So how we diagnose? We aspirate the culture intestinal fluid, and we diagnose by the ingestible wireless capsules, and we treat them by the long term management in the form of amoxiclav, metronidazole, and rifaximin in some cases. Coming to the colon, in the colon we have diarrhea. We have 41% of the patients can have diarrhea, which can be due to the drugs, and 33 to 28% patients can have constipation, and fecal incontinence. So if the patients have chronic diarrhea, the important thing is we need to rule out systemic disorders or the colonic disorders and also to look for the drugs which are causing chronic diarrhea. And the investigation in the form of stool analysis, and some patient calprotectin, and some patient need to rule out inflammatory diarrhea, because we know that diabetes causes motility diarrhea. So to rule out other causes. In the patients who are having chronic constipation, we need to review the medicine, exclude anorectal dysfunction, and start with the increased fiber diet and lifestyle modification, increased movements, and starting with the medications in the form of fibers, prokinetic drugs, linaglutide, prucalopride, and lubiprostone are newer drugs which can be used. The important thing leading to the liver dysfunction is, in the cases of diabetes mellitus, is fatty liver. And the studies show that about 60% of up to 60% of the patients with diabetes mellitus can have fatty liver, and fatty liver after so many days can cause nonalcoholic steatohepatitis, which is now called metabolic associated steatohepatitis, and which will lead to the liver cirrhosis. So every patient and liver cirrhosis will lead to liver failure and hepatocellular carcinoma. Our wards are full now with the patients who are having NAFLD, NASH, cirrhosis, and liver failure and hepatocellular carcinoma. So these patients need to screen for the fatty liver and for the steatohepatitis by the fibroscan, by the FIB4, by the APRI score. So every doctor should do these tests on these patients, and if these scores are higher, then safety margin, then need to refer to a hepatologist. And also the diabetes mellitus lead to the fatty liver, and fatty liver can again lead to the liver related diabetes mellitus. So this study shows that these patients have 58% have steatohepatitis and F4 fibrosis, which is just the fibrosis with regeneration, about 38% of these patients. So I will conclude my presentation that GI manifestations are common. Careful history and objective examination is very important, because these patients have lot of medications. They have diabetic medication, they have which are 3 or 4. They have antihypertensive, they have ischemic heart disease medications, so need to look for their medications causing GI symptoms. And glycemic control, and refer to a gastroenterologist if these patients are having refractory symptoms like chronic diarrhea and dysphagia to do their endoscopy, colonoscopy to rule out organic GI diseases. And NAFLD and NASH, they are the monsters of liver death, and so every doctor should know about them, and we should prevent these diseases by proper history and screening. Thank you very much.
Thank you so much, Professor Mughees, for that insightful presentation on the gastrointestinal manifestations of diabetes. Your comprehensive overview has provided us with valuable perspectives on managing these often overlooked aspects of the disease. It's my honor to welcome another renowned professor of dermatology in this academic session, Professor Dr. Arif Maan. Welcome to the session, sir, and I request you to please join our distinguished panel of experts on stage. Professor Dr. Arif Maan. It is now my pleasure to welcome our next distinguished speaker, Professor Dr. Kareem Kamruddin, the Dean of Medicine at Buckeye Medical University. With a wealth of experience in clinical practice and academic leadership, he will share his insights on topic optimizing the game changer to overcome the clinical barriers. Please welcome Professor Dr. Kareem Kamruddin.
Thank you very much for the kind introduction. Let me correct that currently I am not the dean, I was the ex-dean of medical sciences at Buckeye